Hello, can you hear me? Okay. Okay. It's systemic GIA. Also, juvenile idiopathic arthritis is a chronic autoinflammatory disorder of childhood subdivided into systemic, polyarticular, and oligoarticular. This patient most likely has systemic GI, the most common type, with a varying number of affected joint arthritis, one or more than one joint for more than 6 weeks. Commonly affected include hips, knees, hands. Patient may have arthalgia, as in this patient prior to the onset of the arthritis, fever for more than 2 weeks. Fever occurs in quotidian pattern in which high temperature spikes once daily. Quotidian pattern in which high temperature spikes once daily, often in the evening, followed by spontaneous return to normothermia. An evanescent or pink rash often accompanies the fever, as seen in this patient. Hepatosplenomegaly and lymphadenopathy are common. Supportive lab findings reflect inflammatory leukocytosis, elevated ESR thrombocytosis, and hyperferritinemia. Thrombocytosis and hyperferritinemia. Anemia due to chronic inflammation and IDA is also seen. Rheumatoid factor and anti-nuclear antibody is typically negative in systemic GI. In the setting of classic symptom, quotidian fever, evanescent rash, and arthritis of less than 6 weeks of duration, tentative diagnosis of probable systemic GIA is made. Okay. Okay, regular physical activity. Okay, look at the box first. Strength training, resistance training in children. Resistance training in children. Exercise with free weights and weight machines. Exercise with free weights and weight machines use resistance to increase the ability to exert force. Benefits increase muscle strength and joint stability, endurance and coordination, and increase muscle mass if pubertal or post-pubertal. Pre-participation assessment, cardiac and musculoskeletal examination, assessment of patient's maturity, ability to follow directions, and at typically age at typically age 8 or more than 8. Safety guidelines, proper supervision and equipment, avoid excessive load, mm, contraindication, HOCM, pulmonary hypertension, uncontrolled hypertension. Regular physical activity Regular physical activity is associated with a decreased risk of chronic adult onset disease, cardiovascular disease, diabetes, as well as improvement in blood pressure, cholesterol, emotional well-being, and cognitive performance. Children should engage in more than 1 hour of daily moderate vigorous physical activity, which typically consists of aerobic exercise such as hiking, running, jumping, swimming. Strength training or resistance training is a complementary exercise that uses free weight and weight machine as resistance to increase a patient's ability to exert force. Benefits include increased muscle strength, joint stability, endurance, and coordination. In addition, adolescent can increase muscle mass and athletic performance. Strength training is considered a safe supplement to aerobic exercise in children with following conditions: child readiness, typically age 8 or more than 8, cognitive maturity, ability to follow direction, interest in participation, adequate supervision, qualified, responsible adult professional providing strict oversight, proper technique, individualized, individualized with slow progression, education regarding control movements and well fitting equipment, avoidance of excessive load. The overweight BMI more than 85 to 95% otherwise healthy boy who shows interest in strength training has shown cognitive maturity through his successful participation in organized sports. In addition, his father is a trained professional who has created an individual plan that includes direct supervision, and therefore strength training should be safe for this patient. Okay. Yes, in the stem there is nothing written. You have to diagnose by visualization. This is tophaceous. Yes, I'm here. Okay, this is tophaceous gout. Mm, This patient has tophaceous gout. Gout occurs in the setting of hyperuricemia and is characterized by precipitation of monosodium urate monohydrate crystal in synovial space. In most cases, it initially affects the first metatarsophalangeal joints and knees, where it causes episodic inflammatory monoarthritis. Persistent hyperuricemia can result in chronic gout with tophi formation. Tophi are characterized by excessive monosodium urate deposition in the joints and or soft tissue, leading to chronic inflammatory reaction and nodular deformity of the affected joint. An erosive arthropathy may occur. An erosive arthropathy. Tophi are virtually pathognomonic for chronic gout and typically involves the joints of the hands and the feet. Multiple areas may be involved with severe disease. Other characteristic sites include ear, tendon, and olecranon bursa. Ears, tendon, and olecranon bursa. In acute gouty arthritis, which is exclusively painful and tophi are generally painless. Aspiration demonstrate white chalky material with high levels of MSU crystal visible on microscopy. X-ray may show erosion of the adjacent bone. Okay, pseudogout. Yes, pseudogout. Pseudogout. mm, Calcium pyrophosphate dihydrate crystal arthritis is an acute arthritis resembling gout. However, it is typically monoarticular and usually affects the knees or wrists. Usually affects the knees or wrist. Involvement of interphalangeal joints is atypical. In addition, it usually affects individuals age more than 60. Is it Osgood Schlatter? May not be. There is anterior knee pain 2 months ago. Okay, it's skiffing. Slipped capital femoral epiphysis. In slipped capital femoral epiphysis is characterized by anterolateral and superior displacement of the proximal femur along the physis, along the physis growth plate. It commonly presents with obese adolescent. With chronic hip pain, obese adolescent with chronic hip pain, 15% patient, 15% of the patient with SCFE have only referred thigh or knee pain as seen in here. Due to the referred nature of the pain, knee examination is normal. Characteristics findings on hip examination, however, include limited internal rotation, which causes the foot to pointed laterally, and thigh abduction and external rotation with passive hip flexion. Bilateral hip X-ray are diagnostic. Bilateral hip X-ray are diagnostic for SCFE and shows posteriorly displaced femoral head The patient should be non-weight bearing to avoid further slip, and referred for immediate surgical screw fixation of the physis. Medial meniscus tear usually occurs after twisting injury. Presents with knee pain and swelling. Findings typically include palpable click during knee extension with an internal or external rotation, with an internal or external tibial rotation. Positive McMurray test not seen in this patient. Osgood-Schlatter disease, osteochondritis of the tibial tubercle, is a common cause of chronic knee pain that is worse with running or jumping in active adolescent. Jumping, however, tenderness over the tibial tubercle would be present on examination, not seen in this patient. Is it written in here like tenderness over the tibial tubercle, or there is no tenderness? Yes. Is it rheumatoid arthritis? So what you are thinking? Because in the look at the X-ray, like a radiograph, osteopenia, and there is multiple erosion. Erosive disease is usually RA. We can, yes, because for long-term management we need methotrexate for preventing the joint erosion, preventing the joint destruction. Okay. The two most prevalent forms of arthritis are osteoarthritis and rheumatoid arthritis, and individuals may have both conditions concurrently. OA is much more common and characteristically involve the knees, hips, and distal finger joints. RA is an anti-inflammatory arthritis, typically involves metacarpophalangeal, proximal interphalangeal, and wrist joints. However, any joint may be affected. The patient has multiple clinical and radiograph features suggestive of RA. Her prolonged morning stiffness, systemic symptoms. Her prolonged morning stiffness, systemic symptom, fatigue, soft tissue swelling involving multiple joints are more consistent with RA than OA. She also has X-ray findings that favor for diagnosis of RA over OA, including periarticular erosion seen here on X-ray, distal osteopenia, and soft tissue swelling. Additional evaluation of patient with suspected RA should include inflammatory marker ESR and CRP, which are typically elevated in RA but normal in OA. CCP antibodies are present in most patients with RA and can help to confirm the diagnosis. Rheumatoid factor should be tested but has lower specificity. Initial management of the RA include NSAIDs, systemic glucocorticoid prednisolone to actually reduce pain. However, these interventions do not alter the long-term prognosis and are inadequate for definitive therapy. As soon as possible after the diagnosis is made, DMARDs should be initiated to slow the disease progression. First line option include methotrexate, a folate antimetabolites that is cost effective and well tolerated by most patients. Alternate option include sulfasalazine, leflunomide, hydroxychloroquine. Okay. Okay, this patient with worsening right forefoot with a history of intense exercise and tenderness on palpation on the metatarsal bone likely has stress fracture which can occur in patients who suddenly increase their physical activity, military recruits, runners. Bone response to mechanical stress by remodeling, but an abrupt increase in intensity, duration, and frequency of the physical therapy causes repeated tension or compressive stress to the bone. This can lead to microfracture that eventually pulsate within the cortical bone. Female runners with a low BMI and a functional hypothalamic amenorrhea precipitated by intense exercise are more likely develop stress fracture are more likely and develop stress fracture. Other potential causes of forefoot pain include muscular strain, arthritis, bursitis, motor neuron. Stress fracture is distinguished from the causes of direct palpation or axial loading of the metatarsal joint, which usually causes sharp and localized pain over a bony surface, commonly the dorsal aspect of the metatarsal. In contrast, arthritis typically occurs in the metatarsal phalangeal joints and is not localized in a single bony surface. Bursitis is usually caused by wearing poor-fitting shoes for an extended period, leading to inflammation between the metatarsal head. Tenosynovitis is an inflammation of the tendon and its synovial sheath, presenting with pain and tenderness along the tendon, particularly with flexion and extension. It is usually seen in hands and wrists due to overuse or following a bite or puncture. Okay, this infant likely has nutritional rickets due to deficiency of vitamin D, which is necessary for calcium metabolism and skeletal growth. Clinical manifestations typically appear after several months of deficiency, reflect defective mineralization, particularly at growth plate and sites of rapid bone growth. Findings include enlarged or delayed closure of the frontalis, wrist enlargement, craniotopes, progressive symmetric or asymmetric bowing, progressive symmetric or asymmetric bowing of the femurs and tibia, may occur after children become weight bearing as soon as here widening and costochondral junction rickety rosary on the anterior chest is common and may appear as bony prominence on examination. Vitamin D is made naturally. Vitamin D is made naturally within the skin on exposure to ultraviolet rays. Therefore, risk factors for vitamin D deficiency include limited sun exposure and increase in skin pigmentation. Melanin uh, par partially blocks ultraviolet rays from reaching the skin. In addition, infants who are primarily breastfed without vitamin D supplementation are at risk because breast milk does not provide adequate vitamin D, and few natural foods contain vitamin D. Therefore, homemade baby food without vitamin D fortification, as in this cases, is likely also inadequate. Okay, this patient with arm pain, deformity, and swelling, evidence of radial nerve injury, limited extension of the wrist, joint, and decreased sensation of the dorsolateral aspect of the right wrist joint, has mid-shaft fracture of the mid-shaft humeral fracture confirmed by X-ray. Fractures of humeral shaft are generally seen following direct blow to the arm and a fall, or an automobile injury, or a crushing injury. The radial nerve is commonly stressed such fractures leading to limited wrist extension associated deficits. As seen in this patient, however, most cases represent neuropraxia that resolves after management of the fracture. Although most cases of isolated diaphyseal midshift fracture can be treated, non-surgically. Close reduction followed by arm immobilization with a coaptation or a sugar tongue splint, open reduction and surgical exploration. Open reduction and surgical exploration indicates open reduction and surgical exploration are indicated with open fraction significant displacement, arm shortening, as in this patient, neurovascular compromise, asymmetric radial pulse, as in this patient, polytrauma, and pathological trauma. Okay. Yes. Is it like on visualization? It looks like STD, like gonorrhea. Okay. This patient, okay. Disseminated gonococcal infection. Okay. This patient has manifestations suggestive of disseminated gonococcal infection (DGI), usually presents with purulent monoarthritis. Purulent monoarthritis, polyarthalgia, migratory, asymmetric, small and large joint pain, tenosynovitis, and dermatitis. 2 to 10 pustular vesiculopustular lesion on the distal extremities that may be confused with pimples or furuncles. Fever and chills are also frequently present. Blood and synovial fluid when joint effusion is present. Samples should be sent for culture, but these have low diagnostic sensitivity. Although most individuals with DGI does not have symptomatic genitourinary infection, microbiologic evidence of infection and is generally present. Therefore, a presumptive diagnosis is often made by testing mucosal, urethra, cervix, anus swabs for the pathogen and with a nucleic acid testing preferred or culture. Screening of STD, chlamydia, syphilis, HIV should be performed due to high rates of co-infection. Okay. Metaphyseal. It is either child abuse or Langerhans histiocytosis. Maybe. What is your thought? Metaphyseal corner fracture. The skin bruising is necessary for child abuse, but beefy erythematous plaque in satellite papule on the diaper area, like, isn't it child abuse? The most striking point in here, like medial metaphyseal corner fracture of the distal femur. Look in the box. Metaphyseal corner fracture is always child abuse because femur is a very tough structure, and if it is not done intentionally, it is impossible to fracture here. Okay, this patient has metaphyseal corner fracture. This patient has metaphyseal corner fracture. Such fracture, metaphyseal corner fracture, such fracture, which results from forcible pulling or twisting of and extremity, are rarely incidental and are a red flag for child abuse. Patient with chronic medical uh, patient with chronic medical problems, as seen a patient with chronic medical problems, as well as those with unstable family situation, single parent home, domestic violence are increased risk of for child abuse. In addition, caregivers who were abused or neglected themselves during childhood, as is possibly the cause with the patient's mother who herself had fractures as child and are most likely to continue behavior with their own children. Once child abuse is suspected, the next step in the management is to perform skeletal survey to look for additional occult fracture. Finding concerning for abuse include multiple fracture at various stages of healing, posterior fractures, skull fracture, femur fracture in non-ambulatory infants. Additional evaluation include fundoscopy to evaluate for retinal hemorrhage plus CT scan of the head or intracranial bleeding. Yes, non-accidental trauma, injury inconsistent with developmental stage, delay in seeking care, conflicting historical details, bruise pattern appearance, belt buckle occurring in non-mobile child or over non-injury prone area, ear, trunk, burns, linear, well demarcated fracture, multiple in various stages of healing, femur fracture in non-ambulatory child, posterior rib fracture, metaphyseal corner fracture, and head trauma, retinal and subdural hemorrhage. Disposition ensure immediate safety of child, inpatient management, and child protective service. Evaluation, skeletal survey, CT scan of the head, and fundoscopy. Isn't it? Uh, okay, you give your answer. We are doing same mistakes. Okay. This patient with blunt chest trauma, striking a brick has comminuted displaced right clavicular fracture, comminuted displaced right clavicular fracture. In addition, he has signs of concerning hemorrhagic stroke, hypotension, tachycardia, diaphoresis, subcutaneous bleeding, bruising, swelling in the night, bruising, swelling in the right clavicular area and upper chest. This presentation is concerning for fracture associated, including subclavian vessel, which are in close proximity to the clavicle and typically travel beneath the middle third. Even patient with seemingly minor blunt chest trauma can have serious intrathoracic injury, and hemodynamic instability consistent with ATLS. Suspect patients undergo simultaneous resuscitation, IV fluid bolus, evaluation, clinical examination, chest X-ray to look for um, a life-threatening injury. Further management then depends on their response to resuscitation. Patients such as this one, whose condition improved with resuscitation, undergo further testing to visualize intrathoracic injury because clavicular fracture. Displaced clavicular fracture can injure pleura and lung pneumothorax, or lung pneumothorax, subclavian vessels, brachial plexus. They are best evaluated with CT scan of the chest, typically with IV contrast. Typically with IV contrast. Patients who remain unstable despite resuscitation operating require operating room thoracotomy. Yes. Okay. In blunt chest trauma, if the patient is hemodynamically unstable, resuscitation and evaluation EFAS, chest X-ray, ECG, with or without stabilizing intervention, chest tube if indicated, hemodynamic stability achievement or mentioned, hemodynamic stability achieved or maintained, no, OR for thoracotomy. Hemodynamically stable, high risk mechanism or serious injury on examination, no, abnormal findings on evaluation, chest X-ray, ECG, no, possible discharge or observation. If abnormal findings on ECG on evaluation, yes, additional test, CT chest. If yes, then hemodynamics. Okay, CT chest for blunt thoracic trauma, CT chest. Yes. Sorry. This is the in that line examination show tenderness over the lateral wrist at the radial stellate with the hand held in ulnar deviation. This is a test called Finkelstein test, and it is positive for decurvent tendinopathy. It's a clinical diagnosis. Okay, look at the Finkelstein test first. Yes. So this is ulnar deviation. Pain with ulnar deviation of the wrist due to tendon compartment at the base of the thumb. This is the first extensor compartment. In the wrist, there are 6 extensor compartments. So abductor pollicis longus and extensor pollicis brevis tendon. So, okay, this patient this patient has decurvent tendinopathy. This patient has decurvent tendinopathy and overuse syndrome involving the tendons use syndrome involving the tendons of the abductor pollicis longus and extensor pollicis brevis. Decurvent tendinopathy lateral typically presents with lateral hand or wrist pain, often aggravated by restricted thumb abduction and extension, often aggravated by restricted thumb abduction or extension, lifting an infant under the arms, or forceful radial or ulnar deviation, like opening jar lids, working with hand tools. The diagnosis of decurvent tendinopathy is based on clinical feature. Examination typically shows tenderness at the radial styloid and lateral wrist at the base of the hand. In addition, the pain can be reproduced with provocative maneuver that stretch the tendons by flexing the thumb with the wrist with ulnar deviation. Finkelstein or Eichhoff test. In such cases, no additional testing is needed. Conservative management with NSAID, anti-inflammatory drugs, ibuprofen, thumb, spica splint is usually adequate. Okay. Okay. So this patient has slipped capital femoral epiphysis characterized by anterolateral and superior displacement of the proximal femur along the physis growth plate. During periods of accelerated growth, early adolescent, the physis is relatively weak. The physis is relatively weak due to its cartilaginous composition and rapid expansion. Although obesity is significantly risk factor due to increased mechanical strain of the physis, scaphe can also occur in tall, thin adolescent during growth spurt, as seen in this patient. Classic presentation is insidious onset of dull pain and limb. Minor trauma, as seen in this patient, can sometimes exacerbate the pain and prompt the patient to seek medical attention. Patient holds the affected hip in passive external rotation and exhibit decreased internal rotation. Passive external rotation exhibit decreased internal rotation and flexion. Hip radiograph anterior posterior. Hip radiograph anterior posterior and frog lateral view are diagnostic. Bilateral hip should be imaged for comparison. Bilateral hip should be imaged for comparison and assessed for contralateral displacement. Treatment is immediate stabilization of the physis with surgical fixation to avoid for risk for avascular necrosis. Okay. This patient who required a below knee amputation, this patient who required a below knee amputation following trauma now has persistent pain in the absent portion of the limb. This presentation is most consistent with phantom limb pain and should prompt initiation of a multimodal regimen that includes both pharmacotherapy and adjunct therapies. Phantom limb pain is a complex and incompletely understood pain syndrome that is extremely common, 50 to 85% among amputees. The pain which is perceived in the absent portion of the limbs is usually neuropathic, shooting, burning, and may have seemingly unrelated cause trigger urination defecation. Severe preoperative pain due to devascularizing trauma and postoperative pain is likely increase the risk of development phantom limb pain. Patient with phantom limb pain is typically multimodal, may include pharmacotherapy, antidepressant, anti-epileptic, gabapentin, N-methyl D-aspartate, NMDA receptor antagonist, ketamine, and analgesic, acetaminophen, opioids, adjunctive therapy, biofeedback, cognitive behavioral therapy, and mirror therapy using a mirror to watch the reflection of the residual limb moving at the location of the affected limb. Okay, yes. Regrowth of transected nerve fiber into a tangled mass of the unmyelinated nerve fibers can cause post-traumatic neuroma with a neuropathic pain. Neuroma pain would be temporarily relieved and therefore diagnosed by local anesthetic injection. However, in contrast of this pain, it would be located in the distal amputation stump exacerbated by palpation and percussion. Sorry.
What is it?
CK is high, maybe polymyositis. In polymyositis, I think that a steroid is the treatment of choice. Yes, pyridostigmine for myasthenia. Cyclobenzaprine is a muscle relaxant. This patient has features of polymyositis including chronic proximal muscle weakness, otherwise normal neurologic findings and elevated CK. Peak incidence occurs with Peak incidence occur at age 40 to 50. Women are more commonly affected than men. Proximal muscle weakness typically manifests as difficulty climbing stairs, getting in or out of a low chair or car, or working with the arms overhead combing hair. Involvement of esophageal muscle can lead to dysphagia with regurgitation and aspiration. Inflammatory marker ESR may be elevated, and most patients have undetectable antibodies in a anti-Jo1 antibody. Definitive diagnosis is muscle biopsy. Polymyositis resemble dermatomyositis but without associated skin manifestation. Initial remission can be induced with glucocorticoid. Most patients most patients also receive glucocorticoid sparing drug methotrexate as a therapy to minimize long-term adverse treatment because polymyositis frequently occurs as a paraneoplastic syndrome. Symptoms also receive age-appropriate cancer screening. Which one? Big. Okay. Beta interferon and sometimes used in the treatment of MS, which initially presents at age 15 to 50 with episodic neurologic deficits in different distribution. Episodes are diminished in space of time. Pyridostigmine is a cholinesterase inhibitor. used to treat myasthenia gravis, which is characterized by weakness that worsens with activity and involves the facial and distal limb muscles. In addition to proximal muscle, riluzole is used for ALS and progressive neurodegenerative disorder that causes asymmetric upper spastic weakness, hyperreflexia, lower motor neuron feature muscle enzyme. Sick K is generally normal in these conditions. Okay.